Ah, very good. Welcome to day 5. Let me just set my camera properly. It's nice to see you on a Sunday morning, or rather Sunday afternoon. We have now reached the end of our course. Yes, we started all the way in April and now it's July. So kudos to you for sticking it out. And I want you to remember, you have been assigned this mountain to show others it can be moved. Oh, why am I always in trouble? Why am I always facing hardship? Move the mountain. Others are depending on you to keep the faith. Okay, so let's get going with today's course. Let's make sure that it loads. Okay. Yes, let's talk about assault. Okay. There are many cases that come into, so let's say if you're in an ethics team in a hospital, yeah, or let's say you're in charge of a unit, or maybe, your career in the UK takes you to be the doctor, assigned to a certain care home, and you go there for a couple of reviews. Maybe you're just on a regular floor in the hospital and somebody comes to you and says, I saw a patient being mistreated. Okay. If you go to the person, the one who is causing the assault, and you tell them, it has come to my attention that you have treated a patient inappropriately, and they deny and they cry and they say, I could never do that. Why would people be so against me? Or the one I really like, oh, people are very discriminatory. Since I started here, they've always been gunning out for me. Regardless of whatever the person tells you, you have to escalate the matter. Whether it's true or whether it is false is not up to you to determine. So people get into a lot of trouble. For example, if a nurse comes and complains that they saw somebody mistreating a patient, and then they're like, oh, really? I don't think Betty can do that. And that patient honestly just likes to complain a lot. So, she complained yesterday about somebody else. Today she's complaining about somebody else. So if you ignore it, then you also are not acting in the best interest of the patient. False reports, true reports have to be forwarded to a consultant. Let him decide whether or not this is a false case or a true case. Let us do our investigations. So that's the thing that may that's the burden of the FY2. You would feel that maybe you need to make a decision between such a case and say, okay, I forgive you, please don't yell at a patient again. No, it has to be forwarded to somebody in a higher authority. Okay, so I made a nice case here, and if I was you, just go and look online and just see the cases of maltreatment that people are complaining about staff in the NHS. And even one of the cases I'll talk about today is staff burnout. So people are working very hard. They're not getting the appropriate financial benefit. They are they're not acknowledged that much. So there are many burdens or many pressures on the NHS worker. And sometimes this can relay onto the patient. So there's a lot of work that needs to be done. Anyway, let's go to this case. And then we'll take a break, right? After 1 hour, I'll give you your 2 questions. If Dr. Dominic is here, he's going to do the mock. And then the rest of you can fight with Dr. Busola if she's here to take on the next mock. You are the FY2 in the medical ward. Nurse Betty has reported to you that she saw Samantha Jones and FY1 push a patient into the bathroom. Okay, talk to Samantha Jones and manage the situation. Hello, Samantha. My name is Dr. X. I'm one of the juniors in this department. Don't pretend like you know Samantha. If you're seeing Samantha for the first time, you say it. I'm sorry if I did not introduce myself sooner to you. How long have you been working with us? For the last 1 month. Okay. Do you like the job? How do you feel being an FY1? Is this the first assignment that you're having? Okay. And now you when you're approaching someone who has made a mistake, if you've taken my courses in the past, you don't want to just open the door and say, you're guilty. This is what I had. Never just cut to the chase. Because what if Betty has a vendetta against Samantha Jones? What if the patient is gunning against the doctor? You just don't want to just come in and look like you're biased, okay? So when you're approaching someone who has made a mistake, take it easy. Go in fast and smile. It's so absurd when somebody comes, they're finding me at the desk and I'm busy typing my notes and they're like, hey, Leanne, do you have any idea what I want to talk to you about? What expectations do you have from this meeting that we are having? What? Have you been drinking some orange juice? Have you been drinking some orange juice and you're trying to come and give me your problem? What do you mean? How do I know what's in your brain? So this thing, when ice is good, it has its appropriate place. Okay, it's like a square block that needs a square peg. Ice is not applicable for every single case. So I find it quite absurd when I'm doing a mock and somebody just says, all I need to do is just apply ice. What are your ideas of this conversation? What are your concerns? And what are your expectations? Robotic, all right? So now going to somebody and telling them for the first time, do you have any idea what this meeting is about? I don't know. Maybe you want to ask me out for dinner. Okay, so try and refrain the ideas thing, okay? Introduction, brief rapport, and take the conversation to where you want it to go. She has been reported for maltreatment. So I want to find out in my mind, what are some of the differentials for maltreatment? Is the patient with it? Yeah, so let's find out about the patient first. So do you know, let's say Melissa is a patient. Have you been taking care of Melissa? Yes, I have. Or you can even just start broadly. How are you doing on the unit? What is your patient ratio today? 1 doctor to 10 people. Okay, are you managing this? Okay, yes, I am. Don't just assume it's a challenge. Some people can manage a whole unit by themselves, 100 people, gunners. And nobody will die that day. They'll be all right. And they are on the money. Okay, so don't just go in and say, oh, it must be very challenging for you. Who said it's challenging? Can you not assume? So ask her, how is that ratio of patients to you as a staff? How many nurses are you working with on your team today? Do you feel well supported as an FY1? Okay, you've been working for the last 1 year. Have you taken a vacation at all? Why? I am trying to look for an avenue as to where stress can come in. Okay, so let's put that on the side. What's the patient here with? The patient came in with a broken leg. Okay, how is she doing? She's doing fine. Do we know the etiology of the break? Did she fall? Have we done the test? Was surgery done? That's where you're gathering data. And people say, oh, there are some counseling cases in the Plab. Every case in medicine is counseling. You can't just separate cases and say, these ones are for counseling. I can only counsel these people. Everybody needs counseling. Remember, in the first few days, I taught you about the past, present, and future. Past, present, future is the future counseling. What do you want to know, or what do you want to tell this patient so that they can prevent this from happening again? What are you thinking about this case? How can we help Samantha Jones as our FY1? Okay, then now after you found out briefly, brief focused history, not whether Melissa, the patient, runs around the block 15 minutes a day. Is she a smoker? Is she a drinker? No. I want to find out capacity. How has she been doing? Does the patient seem like she's aware of what we're doing to her? Okay, and now with this broken leg, how is her ambulation? Has she been working with physical therapy? Is she stable on her feet? Melissa could have just stumbled on her way to the bathroom and it looked like she's been pushed. So that's why you are coming in as an investigator to gather data. Yeah. Now, Samantha, I'm very sorry to bring this up, even now, and thank you for just giving me a bit of background on the patient. One of our nurses told me that this morning, when you were ambulating Melissa to the bathroom today, and you would have asked that question before. Have you assisted Melissa to the bathroom recently? Yes, I have. Well, one of the nurses told me that she saw you push the patient. Be clear. Don't say, I may have heard from a nurse, or the nurse is proposing, or I think this and this. If the question is telling you, the nurse Betty reported to you that she saw Samantha Jones push the patient into the bathroom, you want to say that. I've heard from one of our nurses that you have pushed a patient into the bathroom. Then stop and wait for her to reply. Okay? She, of course, anytime you go to somebody, when you attack somebody, the first thing they do is defend. So expect that. Expect a no. Expect, like, are you kidding? What are you saying? I'm actually saying it's actually been hard for me to, come up with the words to talk about this, because, the doctors that we have on the unit are pretty good. I've never heard about a case of maltreatment of a patient. This is why I'm talking to you, to get more information. Now, it can go two ways. She can say, I did not push the patient. I did not do it. It must have been a misunderstanding. I think that the nurse is gunning against me, or she may have seen something else. Are you a prosecutor trying to get her to admit? No. She could say, no, that's no big deal. She doesn't have to admit to you. Just like the way if a doctor comes into work and they are high as a kite, goodness, he's buttoned his shirt off, he's trying to listen to the patients with the wrong end of the stethoscope, and you go to him and say, hey dude, what's going on? Are you all right? You seem a bit off. No, I'm fine, I'm good. You seem like you're having a challenge. I watched you trying to write with a pen light. James, something is really not going on. No, I'm really good. And because I am concerned that you may not be operating at full capacities, you don't have to admit to me, but you'll have to talk to the consultant. So people get really challenged. Even with the OSCEs, they're like, I tried to get the doctor to admit to me that he's using drugs, and he refused. I said, no big deal. He doesn't have to admit to you. What do you do when he blocks you and says, I've not done it, I don't want to continue with this conversation? You want to say, okay, I respect your decision, but it cannot end here. I have a responsibility to our patients. I have a responsibility to you. You do seem a bit incapacitated, or, this is not a decision that remains in my hands as a junior. I'll need to let the consultant know. I will be telling the consultant this in the next 10 to 15 minutes. So please, maybe you can just walk to the consultant and even tell them, Leanne came to me today and said that I look high, So I want you to go and talk about this conversation to the physician. Okay, to our consultant, and let him take it from there. And what are you doing? You are giving him a time frame. In the next 10 to 15 minutes, this is high priority, I am going to talk to the consultant. I hope that you can talk to him before I do. None of this telltale business, oh, go tell the consultant before anybody goes and tells on you. You want the consultant to hear it from you first. Is this nursery school? Oh, do you want me to walk your hand or hold your hand? Let us hold hands and I will take it to the consultant if you are afraid. Please, bologna, and cheese. Let him take his 2 feet and go and talk to the consultant. He is high. But don't get into a place where you're fighting with people. You don't want to get punched. Okay, because you're there saying, oh, I saw you, and I saw you injecting the patients morphine. You're supposed to be giving it to them. You're a bad doctor. You're going to get beaten up in the hospital. These things you relay to further authority. But what is your duty? Because you don't want also to be a weak doctor who just relays everything. You're running to the consultant. Oh, I saw this, I saw the other. You need to help them in your capacity. So this person who is high, give them solutions. Say, all right, to be honest, you're really not doing too well. Ask for the day off. Let's see. And if he admits, yeah, I shoot up a little bit of, some juice before I come to work because I need the strength. God knows the NHS is not paying me enough money. Then now you want to say, let's talk about this later. I want to sit down with you, maybe over a cup of coffee, and then let's talk about this. Let's look at some programs in the community. Now you have a chance to turn over a new leaf. You may not be too fortunate in the future. And if this gets to a higher level where they're seeing that you really don't care about the patients, you don't care about your career as a physician, they might decide to let you go. It takes almost 10 years to get a solid job as a junior. You know, you've worked for 6 years in medical school, you've done your training, you've done all these internships and attachments, you've finally gone through the rigorous interview process, you've been hired in such a competitive facility, you're well supported, and you're just starting your career. You can blow it with a poor decision. And I hope you appreciate, I'm just speaking to you because I want to help you. I'm not here to judge you. God knows I have work to do. I don't need to be talking to you juniors and medical students about drugs. Of course, I'm not going to say that. I hope now you know where my my boundaries are. Oh, now I'm going to go and tell the doctor I don't care because Dr. Lian said. Okay. Anyways, back to this case. I had to branch out to another difficult case because have we had people, oh my gosh, have we had people who are struggling? Yeah. We've had people who, you know, unfortunately are drug addicts, and they are physicians and they are nurses. And we have patients who have just come from surgery. They're on morphine 10 milligrams and they're still paying 10 out of 10. You go and, you know, look at these nurses and or look at the doctors. They are replacing morphine for water. People are struggling. So the patient is suffering, getting 10 mLs of normal saline, and the nurse is just swinging from a tree in the ward, or the doctor or whoever. Okay, so please, now after you've stated clearly, and you have to be firm. Don't be unwavering. Look them right in the eye and say, I have gotten word that you have pushed a patient into a room or into the bathroom. Please let me know what is going on. I was ambulating the patient and they tripped over their shoelace. It looked like they were falling, but I captured them. I held them. Okay. Good. At least I have your side of the story. The nurse has her side of the story. I need you to go and talk to the consultant and maybe he can hash this out. But I just want to tell you that all cases need to be investigated even though they may not be true. Okay? They need to be investigated. Where am I? Here. Okay? Give them a chance. Escalate this to higher authority. If they tell you that, my gosh, this patient is just getting on my nerves, let's get you off that assignment. Of course, if you have pushed them, this cannot go unlooked. Are you having problems with anger? How do you manage your stress? Do you need time off? This is now where you come in with the concern, with the help. Let me help you. Sometimes the patients can really drive you insane. We have all gone through it, but you have to realize that their reactions are part of their disease. She didn't mean to call you a racial term or a racial slur, or maybe she did, but you are the guardian. You are the provider. You are the carer. You can't get to this emotional level with a patient or even get back and forth with them in an exchange of words. Nurse Betty has told you that John Smith, the FY2, called the patient a fool. Why did you get to this point? You have to isolate your emotions from the medicine. This is something they have taught us. And maybe we can review some of the clinical guidelines on how to deal with patient stress. Let's see if we can sign up for some of the trainings that we have in the department. Let's talk to the clinical supervisor. Do you have a mentor in the hospital, a consultant, who you can just go and sit with and talk to? They have gone through everything we are going through now. They can help guide you. But never lift your fist up to punch a patient. Never yell at them. Honestly, there's one care home, I forget the name. The clip shows a staff mocking, taunting, and intimidating and physically restraining a patient. There are people who go undercover in hospitals. In fact, sometimes the hospital itself will hire just undercover reporters Or maybe an agency will just hire an undercover reporter. They'll come in, they'll apply for a job as a carer. They have a camera. There they are sitting with you in the break room, and there you are just talking about a patient and abusing them and saying, I wish I showed you. I got the clip for this investigation, one of the NHS centers. Almost 20 people were fired. Why? Break room conversation. Oh, that patient is a fool. The other day I almost strangled her. And here is the other carer with a nice big button here, just recording them. Cited, people lost their licenses, and the place had to shut down. Why? Even if a patient is mean to you, you cannot be mean to them. If they say something that is really upsetting you, if they say something that is really provoking you, walk away. Okay? It is not worth it. If the patient, you're going to see a patient and she's like, yeah, I'm tired of seeing you black people, man. Go back to your country. All right, thank you, Samantha. Have a nice day. Lucy, can you go take care of Samantha Jones? Thank you. I can't handle that today. But don't put yourself in a situation where you know you're going to be pushed. And even such things, you should be able to report them. If a patient is being aggressive towards you, come on, they can switch your assignment. You've worked too hard to be here. So anyway, all cases are reportable, whether they are hearsay or not. Let the committee make the judgment. But your job is to help that person. They may have some problems with patients. They may have some concerns. Hear them out. Tell them, at least before you go and speak to the consultant, some important things for them to know are, don't approach the patient. If the patient is making a report against the doctor and you go and tell them, Samantha told me that, Melissa told me that you slapped her. One of the big things you have to tell the doctor is, please, between now and until this case is resolved, don't go back into that room. It can easily turn to, oh, the doctor came back here and was threatening me. So if there is a conflict that has been said, don't go back to the patient. Don't try and talk to them again. Let's first go and talk to the consultant. Of course, these are cases of maltreatment, neglect, abuse. You don't want these people to interact with each other again. If it's something like, oh, the patient is complaining because you didn't change my dressing, dude, go change the dressing. You don't need me to come and sit with you and show you how to change a dressing. You should have learned that one in medical school. Okay. Now, one of the biggest complaints you'll see on the ward, honestly, when I go and I get my report, one of the things I usually say is, before I leave, anybody complaining, any patient, family member who is not satisfied with the care today. So I'm working maybe in the ICU, okay? Anyone who's not happy, any family members that are present right now in which rooms, because I want to put stars on those rooms because I know the family is there. If a patient has been admitted, of course, you're going to go and see the acute ones first. It's important just to have these few things when you're getting a report. And I'm trying to even make some videos to help current doctors with how to manage assignments. Such things are very important. If you are in a wing and somebody is in acute situation, you want to see that person first. But if there's a family that's complaining, you want to put that as high priority. Why? These people can escalate so fast and start banging things at the nurse's station and disrupt the whole floor. Never run away from family that's upset. You want to deal with them first, okay? Now, you're the FY2 in the geriatric ward. Melissa Jones has been admitted with complications of diabetes. Her daughter, Samantha Jones, wants to speak to the doctor about her mother's care. She says the nurses are not feeding her mother. Assess and manage the situation. So you go in, hello, my name is Dr. Lian. Are you Melissa? Yes, I am. Can I please know your relationship with our patient? Yes, she's my mom. Her name is Samantha. Can I also just verify her age? She's 72. Okay, I see she's been admitted, according to my note. Where's my note? I can see she's been admitted with diabetes. How long has she had diabetes? For the last 10 to 12 years. Okay, and before we go too far, you had some concerns? Yeah. Your nurses, honestly, they're useless. They don't feed my mom. Okay, please give me more information about this. I come into the ward, I find food from breakfast there. It has not been touched. My mother is saying she's hungry. She's not able to see the plate and feed herself. Her eyes have gone because of the diabetes. She's having a tremor in her hands. She's weak. How does the nurse come and put the tray in front of her and not feed my mother? I'm very, very sorry. You said you found this out today? Yes. So now, what happened afterwards? I just fed my mother the food. Did you let anybody know? Yes, I did. Who did you tell? I told Betty. Let me just jot that down. You told Betty, yes. Okay, and you told around what time? Around midday. I'll go and find out with Betty and see what steps she initiated towards your complaint. I'm very sorry. It's really bad for, for a family member to come in and find that their family member is not being taken good care of. Is this the first time you have noticed this? Where am I going? I'm trying to get old cut, onset, location, duration, characteristics. I'm trying to fit it into the conversation so I can ask my questions in an organized fashion. Is this the first time you noticed? No. Yesterday she didn't eat her dinner. When I came in, it was there, it was cold. Okay. Could it be that your mother is not hungry? Have you considered this as maybe a cause? Because what I need to do is, there are many causes why, your mom is not eating. It could be, yes, that the nurses are not feeding her. It could be that your mom doesn't have a proper appetite. So I need to go and medically assess your mother. Make sure that she's not having problems with her dentition. She's not having any mouth sores. She's not having any sore throat. Poor appetite can be brought on by these things. Even maybe tummy problems or constipation. So I'll do my dutiful, I'll do my duty. Go and assess your mother, see how she's doing. And then I will talk to the nurses. Please, 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 if at all there's anything you're ever going to get from my courses, is don't be a doctor who makes excuses. The NHS is hemorrhaging. Yes, people are overworked and underpaid, but that's not the business of the patient. I'm sorry, sometimes, we are understaffed. Sometimes we don't have too many people. Who cares? The patient is sick. It is not her problem that you're not staffed in your hospital. It's not your problem that you do not have any doctors. She does not care about that. If I go to the hospital, in fact, I had a friend who was in hospital recently. Honestly, somebody who comes in to say, I'm sorry to get you, we are so busy today, can you imagine, we only have 3 doctors. Oh, who cares? It makes my blood boil. Because those are internal matters. Handle it. I have my own problems as a patient. Do I need to know that you are working with locum staff and they are not trained well? Oh my gosh. If at all there's something that really makes my hair electrocuted, is that statement. Stop making excuses for the hospital as a doctor and stop making excuses for the NHS. Handle the problem. I'm here now. Okay. Sometimes, our nurses are not on board with maybe feeding protocols. We may need to revise this, or first of all, make sure that patient is fine, because loss of appetite can be caused by something medical. Okay. Then the second thing, can we talk to the nurses? Let's find out their side of the story. Maybe they come and try and feed your mom and she's not hungry. Can we maybe change her feeding times and feed her as, according to her appetite? Geriatrics are quite tricky when they get a little bit older and maybe they have comorbidities. We have to work according to their schedule. Maybe instead of feeding her 3 times a day, let's switch it to 6 times a day, small frequent meals. Is there a list of foods that you have that are probably, your mom's favorites? Does she like potatoes and steak and vegetables, as opposed to this mac and cheese we are shoving down everybody's throat? Mac and cheese, my cheese sandwich, come on, in the hospital. Tell us what your mom likes. Are there some maybe foods that we can clear with the nutrition department? Maybe she will want you to bring her something that you've made from home. It's fine. It's geriatrics. Pediatrics is a different story. We don't want them eating food from home. But maybe geriatrics, you can you can be a little bit, give them a little bit of a leeway. Yeah, my mom likes the porridge that I make for her. Absolutely, bring that stuff over. Let's give it to her. Okay. Then what are you going to do? Run to the consultant? Let me take a moment of silence for all the consultants who have been disturbed by the junior doctors who can't handle things. Moment of silence. Does my consultant need to know this? No, because I can handle it. Okay. So now you look at the patient, you go talk to the nurses. Can the nurse manager come and talk to the patient's family also so that they can feel supported? I will forward this to the unit manager so that they can also come and speak to you. It's not our intent not to feed your mom. I'm very sorry that this is the picture that you've seen. Okay, maybe I'll put a little note on the patient's chart for them, to be a little bit more patient when it comes to feeding time. Maybe to assign somebody to sit by your mom's bedside and assist her with feeding. Okay. Now there is occupational department, the occupational therapy that works with fine motor, and they can give some devices, adaptive equipment to blind diabetic patients. For example, a plate that is hollow, a heavy spoon or whatever, or something that can just help them know the boundaries of their plate. A plate with 3 sections on it. You have rice on the left, meat on the right, and soup in the middle. So that now with the adaptive equipment, your mom can maybe feed herself. Or we can have a carer feed her. Or, if you're available, by all means, you're welcome, madam, to come and help assist with the feeding with your mother. Okay, what am I going to do now? I'm going to see your mom. I'm going to check her, do a physical examination. I'm going to talk to the nurse. I'm going to see, you said you talked to Nurse Betty. Let me check in with her and see what she has done to help solve this situation. Give me a minute or give me some time to solve this. Do I need to tell my consultant? Do I need to tell my registrar? Absolutely not. I'll handle it. I'll handle this. Relax. Okay. You came to the right doctor. So that's the thing. Now, if it's really bad and she wants to escalate, who does she escalate to? The NHS? People want to give her leaflets for an escalation? Let me give you some leaflets on how you can go and report this matter. How insensitive. If I was in the hospital and a doctor came and told me, I say I want to report the hospital, and you say, let me give you some leaflets or print out some documents and I'll help you fill them out. You didn't even try to change my mind. I tell you as a patient, I want to leave your hospital. It's very crappy, it's dirty, and I saw rats running around here. I want to leave. Oh, it's your right. You can go to any hospital that you want. We are here to advocate for patients. Get out of here. Get out of here with all that nonsense. You need to try and convince somebody who is upset. Make an effort. It's just like if your girlfriend is saying, I'm leaving you today. Oh, let me open the door for you. You can go. Take my keys. No, you want to say, please, please send her one of these love songs. Remember all the times we've had together. What can I do to change? You can ask the patients this. Do you have suggestions on maybe how we can improve? Your complaints are actually good for us. We appreciate when a patient complains because we can use this information to help improve our care. I'll handle it. Consider it handled. As I said, these things are so easy, honestly. But you have to find out about that disease process. Complications of diabetes. How long did she have this diabetes for? What complications is she dealing with? Okay, has the family talked to a doctor to give them an update of what we are doing? Okay, get the full story, right? Now, here's a good one. Because these guys are always quitting. Oh God. The doctor who says, I want to quit the most in the hospital is the junior. Then when they get to FY2 level, they calm down a little bit. only because the learning gap is so high. The learning gap is so high. They're always carrying these books and PDF copies, and you tell them, can you order some antibiotic for the patient? I don't know how much dose should I. Let me get my BNF. They carry around big bags. Okay, let me see my doses. It's okay. They are learning. They are trying. Welcome to the family. Okay. Now, you're the FY2 in surgery. This is where they quit the most. James Smith is the FY1. Okay, he's been complaining about his workload, and the nurse heard him say he wants to quit medicine. Speak to him and manage the situation. Hey, James, my name is Leanne. I'm one of the juniors here. Does it matter how you introduce yourself to somebody? It doesn't matter. There are some people who you want them to call you by your first name. There are others, I want you to call me Dr. Leanne Washira or Gogo Goro Goro Go. Call me by my title, please. It depends, okay? Sometimes when you're just with colleagues and let's say you are, it's in a friendly environment. Do you want to be introducing yourself as the doctor? Do you want to be telling a junior doctor, I'm your senior, I'm in charge of you, I'm in charge of your welfare? No, you're not in charge of anybody as an FY2, okay? We are all on the same ground. So go to James, hi James, I'm Leanne, or I'm Dr. Leanne, or I'm Dr. Washe, it doesn't matter. How are you doing today? I'm doing fine. Do you have a minute? Oh no, I'm so busy. I'm looking through this work here. You know, I have to catch up with my work. All right, what I have to talk to you about is quite important. Please give me just maybe 5 to 10 minutes of your time. I won't take much of your time. Okay, doctor, fine. Thank you. I appreciate. Okay, so you've been here for how long? 2 months. Okay, surgery is quite challenging for the junior doctor. Did you just start in surgery? Yeah. And now the thing is, you need to know junior doctors rotate 4 months in each department. That's a good thing to know. So just in case he tells you, I've spent 3.5 months in this rotation. Oh, so you have just a half month left. Yeah, it shows you've researched into the systems of this country. You're aware. Okay. All right. So you're almost done. 3.5 months. How has it been? You know, are you interested in surgery? Why am I asking these questions? Do I have it here? I'm focusing on directing the conversation to the problem. Okay, that's where I'm directing towards. Let's talk about challenges. Let's talk about coping. Let's talk about your patient ratio. You know, how many patients do you have today? 15. Does that, have you been managing 15 patients okay? No, I haven't. How many FY1s are you on the unit? 3. All right, so 15 patients amongst the 3 of you, or is it 15 patients, so 45 patients for your small little team? It's 45 patients for all of us. Now, coming from a background working in an, on international waters where it's one doctor for the whole hospital, you have to understand that that's actually not good medicine. All right, so how we are overworked in our countries is really not is really not safe. So if a doctor here in this country tells you I am overwhelmed and they have 2 patients only, don't be like, you'll get used to it. Even me, I was in your position. Nobody's talking about you, Dr. Leanne. It's about Dr. James. So don't try and bring yourself into the play and say, you'll get used to it. With time, you're going to build a backbone and you're going to be able to handle. Some people don't with time, and it becomes too much pressure. Okay, so you want to think, be empathetic. So he's complaining about 2 people. What's going on? Are you able to finish on time? What time do you leave the hospital? Have you taken a break? It's now 12:40. Did you have breakfast today? You know, you really have to stay hydrated and you have to eat. Okay. One of the biggest, we actually did a little bit of a study. Kidney stones in physicians in surgery is usually a high number. Why? The surgeons hardly have time to sit down and drink, and so they are dehydrated, and boom, they are crashing because of kidney stones. So maybe you want to mention, I don't want you to get any health complications because you're not taking care of yourself. one of the nurses, and we all work as a team here, and we are very, caring about each other, and we are interested about each other's welfare, because the team is as strong as I don't want to say the weakest link, because this is not football. The team is as strong as its happiest person. Whatever, you can find a word, find another synonym. And our nurse told me that, she heard you talking to one of your friends that you want to quit medicine. I do. I want to quit. I'm done. I'm done with medicine. Okay. Is it okay if we can spend some time and explore this? And I would want to even take more time to talk about this. When did you start feeling these feelings? Okay, when did you start feeling like this? Have you talked to anybody about it? Do you have a clinical supervisor? Do you have an educational mentor? I don't want you to bear this burden alone. Please let me discuss a few things with you. What is the most depressing thing about your job? We start early and we finish late. Where are those reports that we had? What is the issue? Long working hours. They are not being reimbursed. The cost of living is high. So he's getting maybe 500 a week and his rent is 1,500 a month. So he's only having 500 to spend on clothes and all these other things. Interrupted days off. They are only short staffed. There are 3 people on the ward. What is the key issue? Okay, this is not a situation where you'll be talking the most. You'll be waiting for the doctor to speak. Now look, if the number of GPs that has dropped since 2016 was so this was 29,400, and then it is like almost 28,400, almost like a grand. About like in these statistics, I think, were done in 2019. In 3 years, almost 1,000 GPs have called it quits. Now, GP medicine is not that strenuous. So if GPs are having such a hard time, you can imagine how psychiatry is coping, because those guys are always in a burning house. That it's stressful. Okay, so now what's the key issue? Then focus on that key issue, and then you can always investigate around that issue. What else could be going on? Health-wise, family-wise. Do I want to ask him, is he taking alcohol? Is he using recreational drugs? Some questions really destroy rapport unless he brings it up. You may want to ask him, how have you been coping? If you've been having stress, how have you been coping? If he says alcohol, go down that route. But never just assume people just run to alcohol, okay, and drugs when they're having a hard time. If their mood, asking them, how is your mood on a scale of 0 to 10? Don't scale doctors, please. You want to say on average, how are you feeling? How in relationship to this work, how are you feeling? How's your mood when you're coming here? My mood is trash every single day. Okay, on a scale of 0 to 10, 10 being really bad, are you kidding? If they're telling you my mood is trash every single day, the mood is trash. It's below 0. Okay, because it's not a patient, it's a colleague. And this is where that emotional intelligence comes in. You don't ask some questions to colleagues. Okay, it's kind of insulting to their intelligence. And even though their mood is low, you don't want to get to the place of, so every time I ask somebody about their mood and their mood is low, they always have suicidal tendencies. Please be emotionally intelligent about such cases. Now, can they help us? Please help us, NHS, help us. And some things are really, this whole corona thing, NHS has been crying for many years. When Theresa May was in power, she said she'll add over 5,000 doctors into the system. Some people are still crying because even though they're adding doctors into the system, they are not preventing the attrition rate. So you have all these people coming in through med school, international doctors, they are flocking into the NHS. Then they are going to privatize medicine. There are others who, honestly, there are people who are just waiting for their junior years to end and they are gone. Where? Australia. Okay, so the attrition rate, there's no guardian on the doors of outflow. So now what can we do? And even talking to this doctor, you can say, you know, I'm so glad we're having this conversation, because if you speak up, you will be the voice of others who are silently suffering. Examiner, did you hear that? Can you just give me my 12, please? Just give me my 12, because that's a fantastic statement. Okay. How about we set up a team? How about you join the doctor the doctor? How about you make, let's say, let me invent something. Like, can we have a doctors organization that is represented by a couple of junior doctors, a couple of FY2s? The reason you are having this problem is because indeed there is a problem. You are not being supported. There are large caseloads, their working hours are not feasible. So let's try and solve this together. Okay, maybe we can have some petitions to governing bodies to hire more staff. Maybe we can have a pathway where we are increasing the what did we say the other day in my place? We can have a pathway whereby we are increasing the capacity of some of our nurses, like the nurse practitioners. Do they have to keep calling a doctor for an order of Ducolis? Can you just give them some independence in there, or some autonomy, so that the doctor doesn't have to be the person who will always call the doctor for, the patient is constipated, call the doctor. The patient is not working, call the doctor. The patient is, let's try and empower the rest of the staff. Okay, training bursaries is another big thing, especially if you're looking for if you're in academic medicine and maybe you're going to go through a pathway of surgery. You have to pay for your own ATLS course. You have to pay for your own CRISP course. You have to pay for, and these things are like 800 pounds. Okay, so the prices add up. Can we be reimbursed for for trying to improve our own career? Can the hospital be more equipped with better libraries? Can we have better training sessions? Can we have more than one mentor? Can we have a safe working environment? Some people honestly have walked out because they were working in the emergency room and a drunkard came and punched them in the face. But now we have big signs on the walls. We do not tolerate any doctor or staff abuse. You're going to go to jail. You're going to be in prison. We're not tolerating that. Okay. Now, can we have a place where we can discuss our issues openly? All these are nice things for you to say for management solutions. Then let's escalate and talk to the consultant. You're struggling with 15 patients. Let's bring you down to 10. Let's see how you work with that. Maybe you can work with a doctor like Dr. Patel, who's really good at organizing. He can show you how he's managing 20 patients and still getting home at 5 o'clock without breaking a sweat. The guy still smells fresh by the time he's leaving. Let's link you up with somebody who has faced your same challenges. That's how you manage things. And that's why you don't need these recalls. You don't need somebody who's gone into the exam and is coming and telling you, I saw this. Keep your information. Why? It could be different for you. You can't treat today's patients with yesterday's information. What are you seeing in front of you? If somebody is honestly crying because they are so frustrated, now, do you have some tissue to give to them? Sometimes you need to stand up and go to them and pat them on the shoulder. Sometimes you need to move your chair a little bit closer, lean in. Okay, not everybody needs a hug. Not everybody needs to be called my brother, my sister. We're in it together. Put up a candle and let us cry for the departed. No. Okay, can we have surveys of staff? Because if one junior doctor is complaining, you best believe there are others who are really suffering in silence, and they don't want to be deemed as weak. Okay, and now let's see, can we boost morale? Can we get can we make our patients happier? What can we do to make our patients happy? The biggest thing when we get our service back is time. Why do I have to come and wait to see a doctor for 5 hours in the emergency room with my child? I just came from work. I come there, it's 10 o'clock at night, you see me at 3 a.m. What's going on? That's why people are really upset with the NHS. It's the time factor, the turnaround time. We are not discharging patients in the unit, so there's a big backup. Why aren't we not discharging the patients? Who will take care of them in their homes? Where can we can't just discharge them to the street. Okay, we have to support them. So it's a big problem, but you can bring it all the way down to the level of this junior doctor and even tell him, give it a couple of more months, finish surgery. When is your next rotation? Next month. Where are you going? To psychiatry. Maybe it might be a little bit easier there. Surgery is always tough, especially to start with. Hang in there. Okay, you are not alone. I am here with you. I will cross the mountains and the oceans. Those of you who like to use interpersonal skills and IPS and use all these love songs, don't kill a station by saying, I'm your brother, I'm your sister, I'm here for you. You can cry on my shoulder. Really? This is a brand new shirt. Why are you going to cry on my shoulder? And we are not brothers and sisters, please. I have my brothers, you have your sisters at home. So don't be fake whenever you're dealing with a patient. Simple sincerity goes a long way. A sorry and looking at somebody in the eyes and really showing that you're concerned, that you feel them, much better, as opposed to. Now, of all the breaking bad news cases, and I hope that you will never be put in this situation. Of course, breaking bad news, if you go and look at, you just go Google breaking bad news to patients or poor patient outcomes, a whole list of different patient scenarios will come. We've had patients who walk into the emergency room, die of a PE. We've had others die in our hands during CPR. We have to tell the family. ICU, the last case that it really broke me down. I had to go for self-therapy and prayers because I had patients, a young patient, okay, almost the same age, who was found unconscious in a hotel room with a drug overdose. And the thing is, I don't know why I identified with this patient so much. Maybe she just made me think of my life and maybe the crazy things that I've done and maybe gotten away with. Of course, we've not always been paid. And I'm not saying I've taken drugs and all these things. But some people, honestly, their lives, their rewards for their actions are so tough, I have this woman, we're the same age, she's in this bed fighting for her life. She has little kids, all the pictures are on the bedside. Her mother is crying. We know that she is not going to make it. It's absolutely bad case, bad outcome. From the word go, we knew, okay? And the thing is talking to patients, families, who are maybe very spiritually strong and they've been praying for this woman for the last 5 days. They're encouraged. When you're there doing your vital signs and doing your ultrasound scans, you can hear them encouraging each other saying, please, no, God is gonna make a way. Let's get the priest here. Let's pray. Let's anoint them with oil and all these things. And in your head, you have a slither of hope saying, I really hope for a miracle, but it doesn't happen. And now you have to go and talk to these family members. And they know as soon as you call them into a private space. First of all, they're like, can we see our mom? Can we see our mom? Why are you putting us in this private space? So even the breaking bad news you have to do in an exam casts no shadow on how it is in real life. Okay? The worst case scenarios are honestly in obs and gynae. I don't even know how my friends usually survive. Okay, ruptured uterus, the child died. Past medical history, she had there's a crazy case. They were removing some leiomyomas and the procedure was done outside the country. So they really did some bad lacerations to her uterus. So she's here carrying a child, and 26th week uterine rupture. She's feeling dizzy at home, boom, comes back. try to get the baby out, nothing, the baby died. Okay, now what do you tell this mother? Okay, other things, this is another new case that I had. All right, somebody is just coming in clean. I am here to check on my baby. She hasn't been moving that much. I'm a bit concerned. You know what is going on. They check and they see there's a myelomeningocele, or they see that there's anencephaly, and I'm like, how did you miss anencephaly? Anyways, another one who has come in, the child is not moving, and the child is, is not living. How do you break such bad news? The thing is, it now stops being an acting. Okay, and in such, and I feel why such cases are really poorly performed in clinical exams, even in OSCEs. People are coming in with phrases. I'm very sorry, this must be very challenging to you. Just inappropriately putting phrases all over the place, showing insincerity. You want to go into such a case, of course, being very somber. I usually have a little bit of a smile for everyone, whether it's a bad case or a good case. I'll go in, hi, hello, you see my smile. My smile is not, it's just, hello, my name is Dr. Lian. I'm one of the juniors in this department. Okay, I'm just looking through your notes. Can you just confirm your name and your age for me? I'm Samantha Jones. I'm 25 years old. Okay, and I see also that you are 20 weeks pregnant. Yes, I am. We are so happy, doctor. This has been quite a challenging pregnancy. It's taken me almost 5 years to conceive. Okay, did you come by yourself? Why? Guys, breaking bad news doesn't follow like the spikes protocol and all these things. Oh, when you're ready to break bad news, always ask the patient, do you want to hear all the news first, or do you want to hear some of the news? How are you when hearing bad news? Do you have fainting episodes, or are you able to have the capacity? What is all that nonsense? In real life, you want to ask that question of support earlier on. Did you come in with anybody for this visit? Are you waiting for someone? Do you want us to call anybody for you? Not at all. So just give me an overview. How has the pregnancy been going? The pregnancy has been great. Initially, like I told you, we've been waiting for this baby. Me and my husband. Do you have any other children? No, we don't. This is going to be our first child. Okay. Have you had any complications during the pregnancy? This is the 20th week. First 20 weeks, any complications, any headaches, noticing any spotting of any vaginal spotting, blood, okay, any cramping at all? No, everything has been fine. Okay, well, I'm just looking at this update that we did, and even before you go to the update, do your past medical history. Very sensitive for you to ask a question like, in your family, have you had any history of people who are not carrying pregnancies to term? Or I would not put that now, maybe a little bit later, because some of these people are very smart. Well, not even some, all of them. A patient is coming in and they're wondering if they have bowel cancer, and then you ask for family history. Has anybody in your family had bowel cancer? Doctor, I'm worried about breast cancer, and you're asking me if my mother has breast cancer already. It's not just what you say, but even when you say it, okay? Even with HIV, hepatitis, and all these things, the HIV test is positive, and there you are asking them, have you had any positive HIV tests in the past? It's not how you say it also, but when. Okay, so I really hope when you're practicing, record yourselves, hear how you speak, okay, and then go back with books and analyze and say, okay, I need to improve this a little bit better. Maybe I was too eager in breaking the news. All right, so now the time has come for me to talk to Samantha about her pregnancy. Okay, so Samantha, we have done the 20-week ultrasound. Okay, and it's a very important ultrasound for us to do because we are checking specifically for the organs of the baby and how they are developing. Okay, and sometimes it's really even challenging for us when we find that the baby is not developing as expected. Okay, and this is why I wanted, before I tell you what is going on, I wanted you to see if you can have somebody here with you. Okay. Oh, my spouse, no, doctor, you're scaring me. What is going on? You know, according to the report, after we did the ultrasound, which is the jelly scan, what am I doing? I'm trying to extend this thing because I'm also not comfortable doing it. Yeah. According to the ultrasound that we have done, the results show that there are some anomalies, or we have some serious concerns about the neurological development of your child, okay, especially the spinal column. So let's say if it's a myelomeningocele, goodness, you know, maybe they have a nice big outpouching out, and you have meninges out in that pouch, you have spinal fluid, you have, the case is really not that good. Okay, so you want to break it down to them and just break down and say what myelomeningocele is, or you want to say we have noticed that the kidney function is not appropriate, or we've checked the size of the child's, you know, head circumference, the width of the head, and we are noticing that their ventricles or some areas in their head are really accumulating with fluid. Or we've noticed that your child has not had proper development of their arms and feet, or that they are having, there's so many things you can talk about. The heart is not developing well. The organs of the body are developing outside umphallocele. Okay, you never want to tell a mother your child has umphallocele. Have you ever heard about that? I can tell you what it means. Your child has myelomeningocele. Do you know what that is? You never want to do that in Breaking Bad News. Your mother has an intracranial hemorrhage. Have you ever heard about this? You want to break it down. I'm sorry, the results show that she has an extensive bleed to the areas of the brain. This is called an intracranial hemorrhage. You don't want to start saying there are 3 layers of the brain. This is the dura, the subdural. This is where the bleeding is. Okay, in such a case, pen and paper, if you can draw, but it's Breaking Bad News. I don't want my eyes to leave that patient, because there's a big connection when you're talking to somebody and you're telling them sad news. It's best to look at them. Okay, now, once you break the news, what do? You absolutely have to keep quiet. Give the patient time to absorb what you have said. You are HIV positive. I'm very sorry that I'm giving you this news today. Done. Don't say, I wish it would have been another day. I wish we were meeting at different circumstances. I wish I was telling you better news. Your wishes, if they were horses, you would be riding on them. If they were, you would be flying on them. I don't know what that phrase actually even means. Okay, so stop wishing. Give the news. Give it time. In one of my other videos, I think some of the common NHS presentations. Another good video for you to watch in this series. How do you break the bad news? I want you to give time to the patient, but some people really do not know how much time should I give. Do what I do. I count my seconds. So, Samantha, you have HIV. In my head, I count 1, 2, 3, 4. I'm very sorry to give you this news today. 1, 2, 3, 4. Is she crying? Give her the tissue paper. Does she want a sip of her water? Absolutely, let her take a sip of water. Tell her that I am here to answer any questions or any concerns, or if you need any clarifications about what I've just said. Okay. Your child has severe anomalies, or there are some developmental or anatomical changes we are noticing that are quite serious. Okay. But there is something we can do about it. 1, 2, 3, 4. Can I just give you an insight to the plan of care? 1, 2, 3, 4. If the patient is crying, you cannot be talking to a patient who is crying. If the patient is walking around the room saying their prayers, kneeling down, praying, you do not want to be talking at this time. If they pick up the phone and start calling their husband saying, I can't believe what is going, you have to be quiet. If it is brothers and sisters in the room, you've just told them that their mother has had complications in surgery and they are talking amongst themselves, give them the privacy. Let them talk, okay? It's not about finishing this session. I have so many things I need to say. I have so many ideas. Part of your management is how are you managing this critical environment? Does this doctor have the intelligence to know that somebody is suffering a loss? Are they being given time to grieve? What is more important to this doctor? Talking about the management of HIV or just letting the patient have a good cry? What is more important? But you have to, in an exam situation, you have to kind of time it. Because if I only have 10 minutes to talk to you about this case and you start to cry, and you've been crying for the last 3 minutes, we have to get going because I want you to know what we can do. This diagnosis is not the end. Some people really messed up in the mock and they're telling me in an HIV case that I gave them, but it's curable now. We can get you to a place where it is undetectable and untransferable. And I'm like, you've cured me? That undetectability and transferability is not a cure for HIV. There is no cure. Some cancers have no cure, okay? Some of them, and now here's the thing. If the patient asks you, am I going to die? Do you know the answer to that question? You know, if the patient is hanging in the balance, you also hang in the balance because it can go either way. You know, if you survive the stroke and you have complications, we have a support team for you. Physical therapy, occupational therapy, speech therapy, okay? If your child comes out with the deficits of myelomeningocele, there are different recommended therapies, including surgery. Can we cross that bridge when we get there? If the child, unfortunately, is non-viable, and this has been determined by all our investigations, you have to give time for this woman to mourn. If she says, can you do the test again? Absolutely. Absolutely. Doctor, you're telling me that I have hepatitis B. You're telling me that I have HIV. You're telling me that I have metastasized cancer all over my body. All my organs are infested by this cancer. Can you do this test again? Absolutely. Can I get another opinion? Absolutely. I have the results here. And before we give you results, we go through protocol of making sure that indeed they are positive. But for your comfort, I will do the test again. Okay, there are some other things that need treatment immediately. If it's HIV that's positive, then can we start the treatment? Because what is important is getting the viral load to an undetectable level. Okay, so sometimes doing multiple tests to prove and prove and prove again is actually not in your benefit. You need to start the therapy because now what happens is your immunity is being challenged by this condition and you're now exposed to other opportunistic infections, and this now can complicate the care. Okay, this is not hard medicine. FY2 medicine is not hard. One of the best doctors who, when I was doing my clinical rotations in this country, one of the biggest things he told me, if you ever want to be a good doctor in the UK, just grab one resource and master it. Just read it and reread it and reread it and reread it. One big fault with doctors is we love to have multiple resources. Ask me how many books I have in my library that I've never touched. I like to see them, the annals of surgery, the annals of internal medicine, Harrison's books, 500 pounds on a big book like this. It is still crispy. I bought it when I was in medical school. Anyway, yeah, this is really, really not hard. In the end, what do you want to do? it's not a matter for you to succeed. Yes, I gave a diagnosis. Yes, the patient started laughing afterwards. I succeeded because I convinced them that everything is going to be okay. Some cases are unresolvable. The patient, you may leave the patient crying. You may leave the station and the patient is not satisfied with the care that you've given them. They may want to seek another opinion. Absolutely, that is fine. Have I seen miracles in my life, especially in my training, especially with OBGYN? Absolutely. There's a case which was non-viable. It was non-viable. I was there to prove the case. And the woman said, give me 3 days. I don't know where she went, okay? But her husband was quite the prayerful type. And I'm telling you, today she has 2 beautiful babies. I don't understand, but it happens. So now, if you're in a case where a patient is saying that miracles happen, let me go pray. Let me go pray for my father's cancer. We support you in whatever capacity you are in. Please go ahead and pray if you want. Okay? You never want to be the one who says prayer will never change anything, or I'm giving your husband 3 years to live. Leave the consultant to give all those, to give all those outcomes. Your job as an FY2 is safety and support. Okay? Now, do I have mock? Time for a mock. Let's do this. Let's go for our 10-minute break, and then we'll come back and we'll do our mocks, and then we'll call it a day for Sunday. Okay? I'll see you soon. We're going to have our mock now after the break. Let me know when you're ready, Dr. Dominic. Are you ready?
Just give me 30 seconds.
Okay.
Okay, I'm ready.
Okay, and here we go.
Enter station.
Hello, I'm Dr. Opara, one of the junior doctors in the practice.
Hello.
Are you Samantha Jones?
Yes, I'm Samantha.
Okay, can you confirm your age for me, please?
I'm 13 years old.
Okay, Samantha. Are you here with anybody, Samantha?
No, I came by myself.
Okay, Samantha. So I understand you have some concerns. Can you tell me more about these concerns?
Honestly, first of all, I feel like I'll be more comfortable talking to a female doctor.
Okay, Samantha. Well, I understand your concern about that, but maybe you can tell me more about them, and then we can see how we can help you with that.
Okay. I've just been, I've been a little bit late with my monthly cycle.
Okay, Samantha. So you've been seeing your monthly cycle before now?
Yes, it's been very regular, but then now I'm late by, I'm late for a month.
Okay, Samantha. When did you start seeing your menses? How old were you?
I was at the age of 12.
Okay. So are you taking any medications?
No, doctor.
Okay, Samantha. I may ask you some personal questions. I hope you don't mind.
Okay.
Okay. Are you sexually active, Samantha?
Will you tell anybody?
Well, Samantha, issues about sexual health are usually kept confidential, but I can't guarantee that I would tell anybody at this point.
Yes, I am, doctor.
Okay. How old is your partner?
He's 16 years old.
Okay. Does your parents know about
Oh,
this
no,
relation?
no, please, please. Maybe I should go. Are you going to tell them?
No, Samantha, I'm just trying to get a background so I can have a clearer picture of what is happening here.
But you said you don't give me guarantees.
Oh, Samantha,
Why are you laughing at me?
I am not laughing. I'm not laughing at you, Samantha. I'm sorry about that. Issues about sexual health are very, very key and very important. So, but see, because of your age, that was what when we consider if we're going to let guidance know or not. But in this case, you told me that your parents are not aware. So, I would like to know how long this relationship has been going on.
Since I turned 11.
Okay. So that has been going on for about 2 years now.
Mhm.
Have you been using protection, Samantha?
Not all the time.
Okay. Okay. So Samantha, uh, is it just one partner that you have?
Yes, yeah, just one partner.
Okay. So do you feel pressured about having any sexual intercourse?
No, doctor, I love him.
Okay. Okay, Samantha. Uh, so
Do you
Samantha,
think I'm pregnant?
well, Samantha, you're late for about 4 weeks. But before I can say that, we'll have to run some tests to make sure that to check if you're pregnant or not. Aside that, because you told me that you have not been using protection all the time, there are some sexually transmitted infections that can as well be acquired from unprotected intercourse. So we also need to run some other tests
Oh,
to.
like diabetes?
No, not that. Why do you think it could be diabetes, Samantha?
I don't know. I just hear there's so many diseases that have been spread. I don't know. Now I'm so worried.
No, Samantha, diabetes is not spread via sexual intercourse. We're talking about things like gonorrhea or syphilis. So just those are the,
Ew.
yes, Samantha. So, so Samantha, do you have any questions at this point?
So I don't know what to do. I just decided to come here, maybe, speak to somebody who can help me. I don't know if I can keep a baby. Do you offer abortion services in this clinic?
Uh, for your age, Samantha,
Mhm.
uh, I can't. Abortion is a very sensitive issue. I would like to talk to you about other options before we can go into that. You
Two
know, there are,
minutes
there are
remaining.
there are options of adoption. There are also,
Like, so now everybody is going to know what I've been doing. I don't know if I can carry this baby. I don't know.
I understand your concern, Samantha, but sometimes there are families who are willing to take you in. The social services have some arrangements that they can make. There are families that may be willing to take you in. You have your baby, and then they can adopt your child, and nobody would even know what you're going through.
So I'm going to hide for 9 months.
Oh, Samantha, these are options available, but based on what you want, after we've properly given you the options available, based on what you decide, we'll guide you from that point.
Okay.
Okay, Samantha. So it's also important that you practice safe sex because of the infections that we talked about. So we're going to test you for all those infections, And then I would also advise that from now on that you practice safe sex.
Okay.
Is that okay, Samantha?
Yes.
Okay. So have I been able to address your concerns, Samantha?
No.
So what else would you like to be clarified on?
I don't know where to go. I don't know what to do. I don't know where to run. I don't know where to hide.
End of station. Move to your next station.
Yeah, this station. I was confused from the beginning.
It's good. It's good. Let's see. Now, in fact, you know where I caught you? I caught you from the beginning. Let's see what others are going to suggest. Anything he can do to change, or even as you tell me, Dr. Okpara, what would you do to change in this station?
I think there are some protocols I should have thought about and how to implement them in this station, but I completely forgot all those things.
It's important. One of the biggest things, and why I decided to just throw this out there, is a patient who comes in and they said, yes, but he tried. No, you know, these are your colleagues. Of course, they're going to hammer you. The fellow was not smooth. He was not organized. Don't take it too hard. Just you have time to fix the problems. Some of these doctors, can you use IPS, please, when you are trying to encourage people? Okay. Now, a female patient who comes to you and says, can you get me a female doctor? Just surrender. They're usually trouble. Say, absolutely, I can get a female doctor. If there's none available, I can get a female chaperone. Because they are telling you from the word go, I am not comfortable. Yeah, so that's a good thing. And I was busy looking. I really tried to look scared. All this busy business of me looking around, I'm biting my fingers, I'm not maintaining eye contact. It's important for you to talk about the patient's how they are displaying themselves. I can see you looking around. Is everything okay? Are you comfortable? How can I make you comfortable in this situation? Maybe the chaperone might help. Somebody just to sit in this conversation to keep you a little bit comfortable. The thing is, even though it may seem like it's a very benign case, this girl has had unprotected sex occasionally and she's missing her monthly cycle, you still have to do differentials. So now, has she been exposed to any medication? Well, you said she doesn't have, but there's also irregularity of period with PCOS, polycystic ovarian disease. So you may want to just ask, and she's been saying, okay, fine, my period is regular and all these things, just to make sure that it's nothing else medically. Let me ask you a few questions. Any facial hair, chest hair, have you noticed your weight is increasing or not? So now this is your sequence. Yeah, I asked for the female doctor, then you asked me about menarche, which is good. Then you went to medications. Before going straight into past medical history and medications, just get a bit more social. You know, in general, how is your life? How is your day-to-day activity? You're 13 years old. Are you in school? Yes, I'm in standard 7. How are you coping with that? I'm okay. Do you feel supported at home? Yes, okay. Then now you can go into medical history, any allergies, all these other things. And sexuality, good. You signposted. I have a couple of questions for you. Are you sexually active? With whom? What is his age? Okay. And then now I said, will you tell anybody? Well, when it comes to sexual health, what you discuss with me is only used for your treatment. We will not involve anybody else without your permission. As opposed to using that famous word confidential. Just explain it a little bit different. Yeah. Okay. And then now you said, but I can't guarantee. Of course, we can't guarantee, but don't tell them. Don't tell them that. Good, you found about partner age. Is there any pressure in this relationship? And then now I'd get into these symptoms. So she's not had her monthly cycle. Has she done any pregnancy test at home? Okay. And then now, is she facing other symptoms? So weight gain, is any nausea, any vomiting? So don't just focus on the psychology of the case, but bring in the medicine. Also very important. Now I kind of really twisted it for you, because then now I said, what if I'm pregnant? Do you offer abortion services? Always bring back a patient like a fisherman. Reel them in to what is important for the present now. What is important now is, before we can think of anything, let's first make sure, madam, that you're pregnant. Because now you're worrying about abortion, and you've already told her that she can go to a home and they are going to adopt, they may try and adopt her and adopt her children. So you went with her into the future. Bring her back to the reality. Yeah. Okay. Now, what if this case came in and the woman says that I want to make an abortion? We're going to take a little bit more time. We're going to go way past into 2 o'clock, so I can make sure you get a good feedback. What if it was a different case and the woman says, I want an abortion? Well, you've come to the GP service. Yes, we can guide you appropriately and refer you, okay? There are other options, okay? But if a woman comes in and says, I want an abortion, that's where you should focus on. Before 20 weeks, you can do whatever you want. After 20 weeks, then now we get into the legalities of, terminating the pregnancy, because it's illegal in this country. But you don't want your first response to somebody saying, I want an abortion, to be the other options, because it will show, this one has a religion that they are trying to sell to me. Just think about something else. No, anybody wants, absolutely, and will guide you appropriately to that. And then after you say that statement, then you can say, have you considered other options? Then you can gauge, are they interested in knowing that there's a different route like adoption or not? Okay, good. Let's see what these people are hammering you about here. Okay, trouble. The fellow was not smooth, don't mind them. Dr. Yusuf is a bit tough. You must be a surgeon, Dr. Yusuf. Okay, and don't smile. Yes, don't smile. And don't be anxious, but you still tried. You did not explore, plus you have asked if she took a pregnancy test at home. That's important. The pregnancy test at home is important. There we go. PCOS is important. What is this PT, Dr. Aisha? Parathyroid? Physical therapy? I know PCOS is one of the big ones with your a late menstrual cycle. Also use of some pills. If a girl has just recently started her cycle, that would be such a beautiful case. A girl has recently started her cycle and it's irregular, and she's missed her monthly cycle, or she's anorexic, she's not eating well. All these are differentials that can cause a delay in the cycle. And in the beginning, it's not usually regular. As the woman adapts into her new womanhood, then it tends to be a little bit more regular. But another big one is anorexics who have delayed or problems in their monthly cycles. Okay. Now, good try. I would have asked about general well-being. Good. She's young and she's scared. She needs to be comforted. That is a good thing. Okay. And you you assume that the girl is pregnant and was fixated on that. I feel like I'm reading those YouTube comments people write for for videos. Anyway, rule out secondary amenorrhea since she just attained menarche about a year ago, 18 months, and she be allowed for menarche. Okay, abortion before 2 weeks is legal in a minor. Now the big thing here is sexual health in this country. The doctors have woman's choice. Let me just summarize it as that. woman's choice until 20 weeks. After 20 weeks, government choice. Okay, because then now we are not just going to, she had all the time to think about it. Why is she coming to terminate the child after 20 weeks? It's illegal after 20 weeks. Before 20 weeks, woman's choice. Okay. Good job, Dr. Dominic. Any questions for me?
No. Thank you.
Oh, okay, you're very welcome. Of course, I'm still going to be on the chat room. So if you guys have questions about this case, let me know. Thank you so much. So we have now Dr. Busola, yeah? Good, yeah, and please follow the reviews that these doctors are giving you in the chat room. Okay, good. Now, where is Dr. Busola? Let's see. Let me drink some tea so I can have some more power to stress you. And those of you who need to go, I know some of you have some commitments. I'll see you around. I'll see you in Manchester when you come in, or if we do not meet, I wish you a good blessing for this exam. Okay. All right, where's Dr. Busola? Perfect.
I'm present.
How are you doing, Dr. Busola?
Fine. Can you see me?
I can only see just the roof of your house or your office. Okay, good. Now I can see you. All right, are you ready?
Can you hear me?
Yes, I can hear you. And I just want to make sure that you can hear the timer. Okay. And then Dr. Dominic, yeah, good. Okay, he switched off his camera. Okay, let me make sure you can hear the timer.
Enter station.
Okay. You can hear the
Okay.
timer? Okay, good. So let me give you your question. Of course, you don't get the same question. You get, yeah. Oh, sorry, not the flower. The flower is for the end. Come on. Ah, good. So this is your question. I'll let you read it. When you're ready, let me know.
Okay, I'm ready.
Okay. And action.
Enter station.
Hello.
Hello.
I'm Dr. Okolise, one of the junior doctor in emergency department today. Can I know your name, please? Hello.
Hello.
Can you please confirm your name for me?
My name is Melissa.
Okay. What would you like me to call you?
Just call me Melissa.
Okay, can you please confirm your age?
I'm 28 years old.
Okay. How may I be of help to you today?
I don't know. I'm having a good day.
Okay, I can see you with your boyfriend, and
Yeah.
according to you,
Yeah.
looking at your notes, I can see that also that you took some pills. Is that correct?
Yeah. I took just
Okay.
something small.
Okay, Melissa. I would like to know. Do you know the pills that you took, Melissa?
Yes.
Okay. I can see you're a bit dizzy. Are you okay?
Yep.
Okay. I think before I start, I would like to take your vital signs because it seems you're a bit dizzy. Okay. I'd like to check your pulse rates and also your respiratory rates. I think they are essentially normal.
Oh.
Okay. And I also like to do your random blood sugar.
Okay.
Okay. Okay. It seems normal. Sorry, Melissa, can you tell me the pills that you took? You know the names?
I just took a bottle of paracetamol.
Paracetamol, okay. How many times did you, how many tablets did you take?
I just took the bottle. I think it was a brand new bottle.
Hello?
Hello, it was a brand new bottle.
Hello?
Yes, it was a brand new bottle.
Hello, Melissa, can you hear me?
I can hear you, doctor.
Hello?
Uh-oh, it was a brand new bottle.
Okay, how many tablets was inside?
I don't remember.
Okay, but it was the whole bottle you took?
Yes.
Okay, when was that?
About maybe an hour ago. I don't know.
Okay. I'm sorry, what prompted you to take the paracetamol that you took? Oh, sorry. Oh, sorry. I'm very sorry. It seems can you please lie down? Do you mind lying down on the couch?
I want to sit down. I want to sit down.
You want to sit down? Okay. Can I give you some medication to reduce your vomiting?
Yes.
Do you mind?
Yes.
Okay. Examiner, please, I would like to give my patient some antiemetic to reduce this vomiting that she's having. Can I go ahead, sir?
Yes.
Okay. Oh, so Melissa, please, we'll still continue the conversation pending the time the medication will be brought in. Sorry. Are you okay right now?
Yes.
Okay. Okay. Thank you very much. Can we continue with the conversation?
Yes.
Are you a bit comfortable?
I'm okay.
All right. Thank you very much. So right now, Melissa, I want to know the paracetamol that you took. What prompted you to take the paracetamol, the overdose of the pills?
I've had it with life. I've had it.
What do you mean by that?
I'm done. I'm done.
Was there any
I can't continue living like this. I lost my job in COVID. They sent me a letter saying I don't have a job. I didn't go to college. I'd have nothing.
Sorry. I'm so sorry, Melissa. I can't imagine what we'll be going through right now. I want you to just please calm down. Do you understand me? Let's see what we can do. Since you took it about 1 hour ago, when you took this paracetamol, did you take it with any other thing, with water or with alcohol?
I took with water.
Okay, and it was at one dose that you took?
Yes.
Or you took it in stages?
One dose.
Okay, and I also want to know, did you take any other medication apart from this paracetamol?
No.
No. Okay. I want to do some tests for you. Sorry, at least right now you're a bit much better. There are some tests that we have to do as soon as possible to see the level of this paracetamol in you. And I also want to tell you that concerning the job that you lost, it's not actually the end of the road. There are still so many other things that we can do. We can involve our social services that can help you concerning your job. So I would not want you to think that because of that, maybe you want to kill yourself and get overdosed with drugs. So right now, we'll be doing some blood tests for you to check the level of this in your blood. And if the level of the paracetamol is above a particular level that is very high, we may need to admit you and to give you some medication so that you'll be much better. Do you understand me?
Yes.
Do you understand me?
Yes, doctor.
Okay. Is there any other, are you concerned about anything that you want to ask me? Is there anything you want to ask me?
Can I go home?
Presently, right now, you cannot go. We have to observe you. So because of that, we are going to be admitting you. Because there's a particular period, we'll just have to wait a little bit. But by 2 hours time now, we'll take the sample and be able to see the result. And that will help us in our management. Do you understand what I'm saying, Melissa?
Yes.
Okay, right now, because you have vomited a lot, I'll be giving you, I'll place you on IV fluid, normal saline, because checking your vital signs, even though they were essentially normal, but there's no any features of maybe you're dehydrated, but I still want to place you on fluid so that you'll be more hydrated. So pending the time the results of the paracetamol drug level is available, we'll be able to know what we are going to do, and that will determine our management. Are you okay?
Okay.
Okay, and I hope your boyfriend, since your boyfriend is here, will be with you so that he can give you more support. Is that okay with you?
He wants to
And
leave.
after he wants to leave, okay, no problem. If he wants to leave you in what I don't understand, as in end the relationship.
Yes.
Oh, okay. Don't worry, we'll handle that after we've handled this medical issue that we're talking about. And also, because of what happened, we will not be the only thing that.
Move to your next station.
Okay, end of the station. I had to stress you a little bit. Good, good, good. All right. Now you tell me how it went. And let's hear the feedback from the jury. Where are they with their protesting? Okay. Tell me, Dr. Busola. Actually, then before I say anything, let me hear what you have to say.
It actually is a different thing entirely when you're on the hot seat.
A different volume. That's true. That's very true. What have some people said here? Okay, compassion and acute emergency. Anything you could do to change the way you did this case?
Anything I could do? Yes, I will have been more organized.
Okay.
I was a bit tense, and so just going haphazard.
Okay.
And maybe because of tension, I forgot everything about paracetamol poisoning.
It was a good attempt, but I think sometimes we get so involved with I only have certain amount of time to gather so much information, and I need to do all these things together. Now, when you walked into the session, you said, "How can I help you?" Yeah, that's usually I usually say try and refrain from that, especially now because you're in the emergency room. Yeah, by the boyfriend, she has vomited 3 times and he thinks he's taken some pills. Those vital signs you'd have wanted to take a little bit earlier, because she's like this. Oh, Samantha, I can see you, Melissa. You do not look too stable to me. Let me just put you on the monitor. I wanted to give you vitals, but you gave yourself a result, which is I'm glad you did that, because sometimes people do that. The examiner maybe is ready to say vital signs, the BP is this, and the doctor says your vitals are normal, the physical examination is normal, let me ask you the questions. Give maybe 2-3 seconds to wait for results, because sometimes there are results, and you gave yourself results 2 times actually. You said the patient has no features of dehydrations, and you are going to start them on IV fluids, normal saline. Don't worry. You have it covered. Just give the examiner time. Sometimes these people are a little bit old. I'm sorry if any examiners are watching this stuff. Like, they have a long day and maybe they are looking through, where are the results for this patient? And there Dr. Busola has already given herself results. Okay. Now, paracetamol. The thing is with I would try and slow down, because I could tell you're in a rush to gather information, as opposed to saying, okay, so you took the pills today, have you been feeling sad? How have you been feeling lately? So now you're in the emergency room, but this is a psychiatric case. So now you have to balance both emergency and psychiatry. If the vital signs are fine, then now you can switch to the psychiatry. I can see you're not doing too good. I'd like to get to, I'd like to get to get a better picture of what has been happening. Okay, so you took some pills today. Which pills did you take? How has your mood been? Have you been feeling sad in the last 7 days? Every day, how has your mood been? Then scale that mood. Okay. Is there a reason why specifically you decided to take these pills today? and at 10 o'clock or whatever time. I had a fight with my boyfriend. So now it's important just to take your time. Whenever you get to psychiatry, it's more of, I usually make fun of it, it's the shrinking business. You have to shrink that mind, so that now you can be able to get to what led to all of this. Yes, she's seeming like, I even tried to give you a little bit more IPS points, because then I started to vomit. I'm like, yeah. And I started to do like this, like I'm trying to clean myself. But you are so interested in, let's get the labs, let's do all this other thing. That non-verbal language is very important for you to capture. So that now if there's anything that she's doing with the body, you say, okay, do you need some tissue? Or do you need something? And not because we're not in front of each other, maybe it's a little bit different. But I want this team to be so alert with non-verbal language, because that's where you'll grasp all points for IPS. Oh, I saw you scratching I saw you holding your neck. I can see you're holding your chest. I can see you're coughing. Your voice is changing a little bit. It seems your voice is a bit raspy. Do you want some water to drink? Those are now you're covering the communication part of verbal and non-verbal. So don't miss those easy points. Yeah. Now, the giving of the antiemetic may not be appropriate in this case, because she has paracetamol in her system. Much better to let her vomit. But in real life, I would not have mentioned it in this case to give her an antiemetic. There's one big word you told me when I started opening up. You said, calm down, calm down. It might be best not to say calm down, or the words calm down, relax, do not worry, it is okay, it is okay. Those words kind of they can be misunderstood as pushing, like shutting the patient out. Yeah, your best saying, okay, I can see that this has been challenging. I can see that you are worried. I can see you're having a lot on your mind. I'm here for you. Let's talk about it, please. And even with this suicidal risk assessment, starting with, of course, what did she take? Can we stabilize her? Why did it happen? Has she been contemplating these thoughts before? Has she ever tried this before? Did she write a note? Where was she when she took the, so I'm thinking old cut, the onset, location, where was she when she took these pills? So that now you don't jump from pills to vitals to the patient to this. You want to try and get the picture of the woman with this emotional stress. She's felt like she has had enough. She goes to the bathroom, takes the pills. Was she thinking about this? What else did she do? Did she try to take other pills? Did she try to injure herself in any other way? Because she may have taken a stab to the femoral artery. So any form of injury you want to explore more, all right? And then now after that, you want to, so I said over here, try and slow down a little bit better, slow down a little bit. And even though the patient seems like she's looking a little bit better, you want to ask her, so you're not assuming. Because you said to me, you look much better, okay? Now take your, so don't give yourself results in the exam. This patient is doing okay. Yeah. So after you've done that suicidal risk, a very important question is, do you have any thoughts as to what has happened? Do you have any regrets about what has happened? Do you have anything to look forward to? Who is your support at home? You live with your boyfriend, your mom, your dad. Can we call anybody else for you at this time? Okay. Sometimes we may get to a place where, so even before you tell her the social services will help her find a job, attack now the thoughts, the bad thoughts that led her to try and commit herself. So you may want to say something like, you know, Samantha, just from what you've been telling me, you've been having a hard time. You've lost your job. Your boyfriend is leaving you. It's the COVID situation. There are times where we feel that, you know, we are in an impossible situation. And I want you to know what to do if you feel like this again. Always reach out to someone. you know, and maybe even now, I would want you to sit down with one of our counselors and talk more about how to cope with such a situation. So now you're thinking, the management, remember the very, very first lesson we learned, the management action. Admission, are we admitting them? Are they going to observation? Or are they going home? Blood work, ABCD. So blood work, paracetamol levels, the liver LFTs you want to check also. So I want you to mention these things. Then say IV fluids was perfect, because you can say now you vomited three times, and then this is the fourth time. We may need to replace that fluid. Check your electrolytes also. Okay, sometimes if you've taken a high dose of paracetamol, it's important to protect the liver. So sometimes you want to give a little bit more of elaborated management. Yeah. Sorry, I'm just talking. I really like these psychiatric cases, because every now and then you want to go back and give her reinforcement. Okay, let's keep you here. Let's find out what is going on. Let's see if we can support you better, because challenges will always be there in life. It's just how our outlook. It's how we take a hold of these challenges. This is not the end, and at least you did say a few good words in the end, especially with stabilizing the patient and getting care of getting the involvement of the social services. And then you can ask her, now, you know, thinking about this, is this something you would, what is your outlook on the future? Because there's a tricky patient who comes in and says, I will never do it again. And of course that one, even though she's not going to do it again, we still admit. Yeah. Good. This was a challenging case, because I kind of put you in an emergency and psychiatry together. But I'm glad you pulled through. Just slow down. And in fact, you know what? You have a lot of time. And sometimes people think this time is really too little. You have a lot of time. So take it easy. Take your time.
All right, thank you very much.
You're very welcome, Dr. Busala. It was nice to meet you. Now, let me see what this jury is telling you here. Okay, they're saying good, compassion and acute emergency. It was a good attempt. IPS, vitals earlier, yes. Take the bloods and start the NAC ASAP. Yeah, you can mention that. In avoiding the reduction of the vomiting, yes. So you don't want to suppress the vomiting, actually. Yeah. The big thing, good attempt, okay. To do a pregnancy test was important too. Now that's that's a nice thing to say, but depending, because sometimes these patients, they'll take paracetamol, sometimes they'll take another type of medication. I don't know if Dr. Busola, you realized in the beginning of the station, I was like picking things from the air, because I was trying to suggest, am I hallucinating? Am I seeing? Did you see me do this in the beginning?
I didn't.
Yeah. I was really having fun with the case, because I was like saying, what should I make this? Should I make it like a drug overdose, PCP overdose or something? But I was doing something with my fingers. When you watch the video, you realize I was doing something with my fingers in the beginning. So, huh?
I have questions, please. You said we should not give antiemetic at the beginning, but this patient was just vomiting, even in my presence. What would I have done?
Now, and the thing is, because she has taken an overdose of drugs, so the body is trying to relieve itself from this toxin. It's like somebody who has had food poisoning and then we give them Imodium to stop the diarrhea. It's the same rationale. We want it out. And in fact, sometimes they may even pump that stomach. They may put an NG tube and try and get it as much as possible out. So saying the antiemetic...
So I'll just be vomiting.
I'm sorry?
You just continue what I'm asking and still the patient will be vomiting.
No, so the patient vomiting, I would offer maybe some tissue or a bucket or and even maybe to even say, you know, you have taken a lot of medicine, so the body is even trying just to get rid of it. We want it out better than in. Is it okay for me to continue? Do you want me to give you a glass of water this time? I can pause for a few seconds for you to gather your breath. You see, so that it's actually the IPS that would have handled that situation, as opposed to saying, I want to give antiemetics. Good, thank you for asking. Now I understand what you asked. Yeah. So sometimes the IPS is a good solution, as opposed to say, stop everything, give me antiemetics. Examiner, I want to stop this vomiting. Yeah. Sometimes it's bringing the bucket closer to her, giving her some water. Does she want to take a few minutes away to go and rinse them out? And this is the thing, even with this exam. There are some cases that you'll feel, I honestly don't care about the points. I don't care about passing or failing this station. This is real life medicine to me. I'm in front of somebody who is sick. I'm not thinking about time. I'm willing to give up this case to make sure that this person is okay. Because even sometimes in our OSCEs, they brought, we had cases with hypothyroidism and cases with obese patients who wanted to have bariatric surgery. And the actors that they brought were people with very high BMIs. So they are sitting in that station and we are looking at them, and even when I talked to my colleagues, I said, I hope you understood that this person is actually struggling with weight. It's not just on the paper that their BMI is 40. You can see their BMI is 40. You can see their esteem is really low. You can see they're really struggling. They're telling you, I have been trying to go to the gym. I've been trying to exercise. Nothing is working for me. So it's not even an acting. Some of these people are actually having these cases, and the points or the station or the exam doesn't matter. And for cases that we took as real life and tried to touch the heart of the patient, we excelled in those cases. Yeah. So sometimes the IPS can really carry. Good. All right. So good. Check the vitals. Now, I think if you suspect a patient took more than 24 tablets of paracetamol, you don't wait for 4 hours to give N-acetylcysteine. You want to mention the N-acetylcysteine very early, at least to protect the liver. Yeah, good structural approach, sympathy. Things I would suggest you to improve our listening skills. For example, you asked how many tablets the patient took several times repeatedly. Good. I also picked up on that. You dwelled a little bit on the paracetamol. You said, sorry for vomiting. I think as a broad doctors, we overreact to sympathy. Too many sorries. Okay, yeah. Maybe not too many. Yeah. You did not ask about suicidal thought and depression. That is important. Yeah. Taking of any other medications, at least you said about the alcohol, but the details of this event of suicide are important, including the note. Yeah. And the good, excellent point you did was the vital signs. Fantastic. Good. Dr. Lian, please, in the exam, if a patient requests for a female doctor, how do we go about it to continue the station? Thank you. The patient has said, I want a female doctor, and you're a male doctor. You want to say, okay, I'm part of the team. Okay, we do have some female doctors. Would you want me to, because sometimes they could be on different assignments, and just so that, I can use this time efficiently for you and rule out any emergencies or just do my preliminary examination, would it be okay for me to have a female chaperone for you at this time? Someone who can just sit in the conversation and to give you a bit more comfort, because that's what happens in real life. Some patients come in, and most of them are females, and they say, I just want a female doctor, please. You have to offer them, I can get you a female doctor as soon as possible. In the meantime, can you work with me and a chaperone? I'll not do any physical examination. I'll just ask the questions, and then the physical examination can be done by a female doctor when one becomes available. Please, female patients are trouble. The ones who show you from the word go, they are not comfortable, back off, because they may have some experiences. They could be trouble seekers, but most of the time it could be a religious thing. They really do not want to expose their body to any other man. So we have to respect that. And it usually comes with the guys. Even in terms of compassion, it's much better for, if you see maybe the woman is crying and you're a male doctor and you really want to reach out, reach out with an attempt of your body by just saying, you know, I'm here for you. So you're moving your chair closer. This male to male is fine. You can go tap the shoulder, it's fine. But some doctors have gotten into trouble where, you know, they're trying to touch the shoulder, but by mistake, they just slip. They slip, you know, instead of going distally, they go proximally. And then now the patient starts to say, this guy was trying to go for my chest area. And the guy is saying, no, I just wanted to give her, you know, a pat on the shoulder, and she did. So sometimes it's best to reach out with your hands and not actually touch, but be like, I'm here for you. I'm here for you, okay? The female people, you can do as much as you can. But then again, you want to be also careful with the opposite gender. Because then you don't want to be, oh, that doctor has very sticky, itchy fingers, yeah? Now, good. Medical conditions you can also ask. I think it was a challenging station because I gave her like a dual emergency psychiatry. So she was trying to really balance it. But she did a good attempt. Good attempt, Dr. Dominic also, Dr. Busola. Okay.
Sorry, Dr.
Yes.
Lian, please.
Yes.
I have a question.
Mm-hmm.
In that question, you can see the boyfriend is there. Is there any important? And I noticed it's as if I ignored the boyfriend. I never made any attempt of even. Is that boyfriend going to be in the room?
Now the thing is, okay, go ahead. Mm-hmm.
He came with her boyfriend, and I noticed that I didn't even acknowledge the presence of that boyfriend.
If the boyfriend is in the room, acknowledge the presence. If he's not in the room, you can ask, where is he? I know the mock's a little bit challenging, especially if now it's just on a screen, but anybody in that room, you want to acknowledge their presence and even ask the patient, is it okay for me to continue with your spouse in the room or your boyfriend in the room? Yeah, that's a good question also. Yeah, it's good. But the main history comes from the patient. Okay, and then even before you ask the boyfriend anything, you can ask the patient, is it okay for me to ask some questions to your boyfriend because he's the one who found you? Then she'll say yes. Then you say, okay, how did you find her? Where are the pills? Did you bring the bottle of the pills at all? Did you know, was she conscious? Did she have a seizure? Okay, then around what time did you find her? When was the last time you spoke to her? Because then now that the history for the boyfriend is different, because he was the observer. Okay, how did you get here? We came by ambulance. How has she been lately? How has she been coping with life? Have you been having any conflicts in between you in the home? That's now the questions for the boyfriend if he's there. That probably would be a 20-minute station. But if you're talking to the patient, focus on now how she has been and how she has been coping, what led to this, and even in the end, telling her, you know, we cannot really predict the future. We may get another situation like this pandemic. We may get other challenges in the future, but I want you to be able to handle the future with confidence and not resort to trying to take your own life, but instead reaching out to someone, to a family friend, to a family member. There are some hotline numbers that you can give you. But what is important for us is to make sure you are stable now, and then just to guide you to navigate from this situation or from this place that you are in. Okay, I'll come back and I'll check on you a little bit later on. I want to find out a little bit more about you. I'll involve the referral to the psychiatrist. You may see that, you know, we may have somebody in the room just to keep an eye on you just for the first couple of hours. Okay, any questions at all, please let me know. You're not going to tell her we are putting you on suicidal watch, but you're just giving her a heads up. You know, if you see us coming in and asking you maybe the same questions repeatedly, we're just trying to get a better picture, because from this picture we'll be able to manage your care properly. Okay, Samantha? Yeah, so that's how you want to do it. Yes.
Sorry, please.
Yes.
Type of case, do you do leaflets?
No. Such cases, leaflets, no. Breaking bad news, leaflets, no. Because the thing is, I want you to put yourself in the position that you just tried to kill yourself, and now the doctor wants you to go and read up on suicide and how to prevent suicide. No, some things are much better speaking to somebody about. That's even with, especially with breaking bad news. That's a good point you brought up, because some people likes to say, I want to give you some leaflets to go and read on how to manage your grief and dying and all the dabga you'll go through, anger, depression, bargaining, outbursts and all this. No, can I have another session with you to discuss how we can move step by step from where you are right now to a place where you can finally accept what is going on with the loss of the child, with the loss of the spouse, or with the loss of the job and what have you. Okay, leaflets in this, yeah. So these heartfelt cases, try and avoid these leaflets. Okay. Oh, good. So we actually have come to the end of our 5-day course. I wanted you to see this nice, beautiful flower. It has been an absolute great pleasure, to be able to work with you for the last 3-4 months. And I really pray the best outcome for you. I hope that you will not come to another Plab class of mine. I hope this is a one and done. Yeah, you go in with confidence, get a good connection with your patient. Forget about the examiner. They're just there to see how wonderful you are. Okay, you have to be safe, because if you do not understand what is going on in the station, if the patient's accent is too heavy, it's not clear, you want to say, please, are you able to just slow down your pace and speak up a little bit louder? Can I move a little bit closer so that I can understand what you're saying? Everything that I'm collecting, all this information, is just to get a better plan in order to manage you. Okay, we don't make any excuses. We work as part of a team. We understand that even though we offer our patients the world, some of them will never appreciate it. Okay, it's fine. Don't take it personally. Okay, some people will yell at you, some will abuse you, some will punch you and kick you. It's part of their disease. Okay, you always have a support, your consultant, your registrars. So use them appropriately. Not every case is sent to the consultant. Some of them you can manage. So ask for an opportunity to make things better. Okay. Stay safe, stay healthy. God bless you all. Until next time. Goodbye.